Greetings. I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's June 2021 issue. There are 3 articles, one of which focuses on COVID-19, that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice is an original article examining the power and precision of predictive genomic testing that is entitled Clinically Actionable Findings Derived from Predictive Genomic Testing Offered in a Medical Practice Setting. It is authored by Ms. Jennifer Anderson and colleagues from Mayo Clinic in Rochester, Minnesota. The interplay of nature and nurture is uniquely relevant to disease susceptibility, as the latter is governed by genetic determinants and environmental and behavioral determinants. Environmental and behavioral factors that reduce such risk are widely agreed upon, and these include clean air and water, sanitation, cardiorespiratory fitness, a Mediterranean-based diet, stress reduction, and avoidance of smoking, among others. Of rapidly growing interest are the genetic factors that lurk unseen in otherwise healthy individuals and which may be harbingers or determinants of subsequent disease. The development of next-generation sequencing and related technologies has significantly advanced the exploration of such genetic determinants, broadening genetic testing from its relatively constricted focus of probing for a single or limited number of genes in individuals with a relevant personal or family history to a much more expansive and encompassing one termed predictive genetic screening. Such screening examines panels of genes and their respective variants. In the present issue of Mayo Clinic Proceedings, Anderson et al. Report on their retrospective analysis of findings derived from predictive genomic testing undertaken in the clinical setting. The study population involved essentially healthy individuals followed in the Mayo Clinic Executive Health Program who chose to undergo such testing. In the pretext phase, these participants met with a genomic nurse and a genetic counselor, and a 3-generation pedigree and family risk evaluation was undertaken in each participant. Thereafter, participants selected one of 3 available predictive genomic testing platforms. And in the event that a personal or family history raised particular concerns, participants were counseled by genetic counselors on the platform that may be the most appropriate. Variants were categorized into one of 3 groups that included, first, clinically actionable genes based on the American College of Medical Genetics and Genomics Working Group's compilation of 59 genes that are mainly incriminated in cancer syndromes and cardiovascular disease. Second, risk alleles, and third, carrier status. The findings of Anderson et al. Demonstrate that almost 12% of participants had at least one clinically actionable result, with genetic variants largely involving pseudocholinesterase deficiency, familial hypercholesterolemia, cardiomyopathy, myopathy, and hereditary syndromes involving breast and colorectal cancers, breast and ovarian cancers, and colorectal cancers. Approximately 50% of participants with clinically actionable results involving hereditary cancer genes warranted genetic assessment according to the guidelines of the National Comprehensive Cancer Network. Some 50% of participants with clinically actionable results were without a relevant personal or family history for the gene that was detected. Well over 50% of participants were carriers of a recessive condition, and with more than 40% of participants exhibiting a variant for multifactorial disorder. This analysis by Anderson et al. Is important and timely from several perspectives, including the following. First, it is one of the very few studies, if not the only study, which undertook such an analysis in a clinical real-world setting and not within the context of a research protocol. Second, it uncovers the relatively high prevalence of such genetic variants with clinically actionable findings in otherwise healthy individuals. Third, it underscores the discerning power of this technology as pathogenic variants are detected in a substantial number of individuals without any personal or family history for hereditary diseases. Fourth, it provides a paradigm and a process for providing predictive genetic screening in large medical centers. Fifth, over the 5-year time frame in which the analyses were conducted, it shows how newer platforms and updates can be effectively incorporated, a particularly relevant consideration since innovation and refinement in these technologies will indubitably occur in the coming years. And sixth, it holds out the hope, a broadly held one in the provision of healthcare and medical practice, that by detecting pathogenetic footprints which presage the development of disease, remedying or mitigating the disease and its consequences may be more likely achieved. Our first highlight this month is on fecal microbiota transplantation in the time of COVID-19, and is an original article entitled Fecal Microbiota Transplantation for Recurrent C. difficile Infection During the COVID-19 Pandemic, Experience and Recommendations. It is authored by Dr. Sahil Khanna from Mayo Clinic in Rochester, Minnesota, and colleagues from the University of Chicago Medicine, Chicago, Illinois, the University of Minnesota in Minneapolis, Minnesota, and Boston's Children's Hospital in Boston, Massachusetts. A major cause of healthcare-associated infections, C. difficile infection, afflicts approximately 500,000 individuals each year in the United States, is recurrent in more than 80,000 patients, and imposes almost $5 billion in healthcare costs. Each year, C. difficile infection causes some 30,000 deaths. For patients with recurrent C. difficile infection, experts recommend fecal microbiota transplantation as a preventive strategy because of the remarkable efficacy with which fecal microbiota transplantation decreases recurrence of C. difficile infection. However, as is true for so many aspects of healthcare, the practice of fecal microbiota transplantation has been challenged and constrained by the current COVID-19 pandemic for reasons that include, among others, the following. First, fecal microbiota transplantation is generally considered an elective procedure, and at certain stages of the pandemic, especially during surge situations, elective procedures were placed on hold. Second, SARS-CoV-2 can be transmitted via the fecal oral route, but the likelihood and duration of such transmission of SARS-CoV-2 in asymptomatic individuals are currently unknown. Potential stool donors thus need to be effectively screened so as to avoid the transmission of SARS-CoV-2 during fecal microbiota transplantation. Third, a validated test to determine the presence of transmissible SARS-CoV-2 in stool is currently unavailable. And fourth, supplies of donor stool obtained and banked before December 2019, that is, well before the start of the pandemic in the United States, have steadily decreased in medical centers and in critical nonprofit stool donor banks, such as Open Biome, the latter currently unable to supply donor stool for fecal microbiota transplantation. In the present issue of Mayo Clinic Proceedings, Khanna et al. Report on their experience with fecal microbiota transplantation during the pandemic. The donor aspect of this experience involved two institutions, Mayo Clinic and the University of Minnesota, both of which had established donor programs. Every 2 weeks, donors were screened for symptoms and a history of exposure to cases of COVID-19 by a nasopharyngeal PCR test for SARS-CoV-2, and in the case of the program at Mayo Clinic, by appropriate serologies to delineate past exposure. 2 donors in the donor program at Mayo Clinic during the pandemic tested negative for SARS-CoV-2 and donated stool samples used for fecal microbiota transplantation. 2 donors of the 6 donors during the pandemic at the University of Minnesota tested positive for COVID-19. Because of adequate donor material collected and manufactured before December 19th at this center, donor supplies obtained during the pandemic have not been used to date for fecal microbiota transplantation. Fecal microbiota transplantation was performed in 57 patients from May 26, 2020 through September 30th, 2020 at Mayo Clinic. This study by Karl et al. Is significant for numerous reasons. First, it calls attention to yet another aspect of healthcare adversely impacted by the pandemic. Second, it shows how experiences at 2 medical centers may inform responses to challenges imposed by the pandemic in caring for patients with recurrent C. difficile infection. Third, it demonstrates how a fecal microbiota transplantation program for recurrent C. difficile infection can be currently maintained in these challenging times, and with such a program not only conferring its expected efficacy, but also avoiding the transmission of COVID-19. Fourth, it offers recommendations derived from this experience. And finally, it highlights the need for further understanding of the likelihood, temporal profile, and pathobiologic significance of the excretion of SARS-CoV-2 in the stool in infected patients, as well as the need for a test that reproducibly and accurately assesses such viral presence in the stool. Our second highlight this month is a review article that discusses the challenges faced by physicians who are or will be mothers. It is entitled Challenges and Solutions for Physician Mothers, a critical review of the literature. It is authored by Dr. Sherry Chesak and colleagues from Mayo Clinic in Rochester, Minnesota. Physician mothers face 2 sets of challenges. The first set arises because of the challenges and inequities traditionally encountered by women pursuing careers in medicine. The second set originates from motherhood itself, its ramifications, and all that it entails. The challenges are complex, multi-layered, and in some instances catalytic. For example, because of the duration and demands in medical training, which may entail medical school, residency, fellowship, and subspecialty fellowship, women may delay pregnancy, and such a delay itself may lead to additional issues such as an increased risk of pregnancy complications, infertility, and the possible need for adoption if parenthood is desired. As another example, re-entry after maternity leave into medical training or practice is accompanied by additional responsibilities of childcare and parenting. While this issue is certainly not unique to physician mothers, the medical training or practice they are re-entering is commonly quite exacting. There are very few, if any, comprehensive reviews of the available literature on this topic, a deficiency now rectified by the discerning article of Chesak et al. In the current issue of Mayo Clinic Proceedings. Starting from almost 1,200 articles from their search strategy, the authors gleaned 71 that met eligibility criteria, and these included a mix of qualitative studies, quantitative studies, and studies using multiple methods. From these studies, the authors extracted and compiled salient challenges that were identified and potential solutions that were offered. Challenges delineated in these studies were grouped into those with shared themes, the latter then categorized by Chesak et al. According to 3 levels of influence of these themes. The individual level involved, for example, issues pertaining to work-life balance, career progression, pregnancy complications, infertility, timing of pregnancy and adoption, and mood disturbances and burnout. Themes at the organizational and healthcare system level included lack of mentors and networks, impediments to breastfeeding, family leave policies, relatively inflexible schedules and demanding hours, and inadequate support for family planning and child rearing. Finally, challenges were identified at a societal level, and these involve issues pertaining to gender inequity, maternal discrimination, and childcare. Chesak et al. Also synthesized strategies and solutions that can mitigate these challenges, emphasizing the importance of mentoring, the support of childbearing and childcare, improving family leave policies, promoting professional growth and fulfillment and work-life balance, and dispelling the maternal bias that exists in medicine. While issues delineated and discussed by Chesak et al. Are broadly applicable to women irrespective of their profession, career, or occupation, the special importance of the article by Chesak et al. Is its persuasive clarion call to the medical community that physicians who are or wish to be mothers must receive much more support and resources. You can access these highlights and editor's choice articles free of charge during the entire month of June. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you'll find links to our social media by clicking the buttons at the bottom of any page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and Author Insights podcast recordings, which are available from our website on the homepage as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who have made a strong impact in their field of study. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of the issue. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.